Thank you very much, and thank you to the Scottish Sentencing Council for inviting myself and my colleagues to present at this conference on mental health, neurodivergence and learning disability in sentencing. Now, I have the task of speaking on psychosis, and as I see many of the audience are very familiar with this concept and are mental health professionals. So I would ask the whole audience, but that group as well, to consider as I speak, sentencing for psychosis, does it work? But before I get on to psychosis, I'll consider briefly the whole concept of mental disorder. I will address even more briefly personality disorder, and then I'll talk about the links between the criminal justice and mental health systems, legislation available to us, the pathways through our forensic mental health services, and lastly, the outcomes, the knowledge that we have on what happens with our patients. So first off, what is a mental disorder? And the definition to the left comes from the World Health Organization. A mental disorder is characterized by a clinically significant disturbance in an individual's cognition, emotional regulation, or behavior. It is usually associated with distress or impairment in important areas of functioning. And because in mental health, we often don't have a definitive blood test or a scan to make a diagnosis, international classifications of disease are very important to us because they set out the symptoms and signs of the various disorders. And that means that worldwide, we can know that we are consistently talking about the same disorder. And in terms of research, when we look for what works in terms of treatment or what the likely prognosis is, again, we are studying the same disorders. Now, ICD-11 is what we use in the UK to determine our statistics, and it has subclassifications as set out on the right here. And it is only some of these areas that we will be addressing today, albeit for all of us at some speed. What does the Mental Health Act say about this? So the 2003 Act says mental disorder means any mental illness, personality disorder, or learning disability, however caused or manifested. And there are a number of exclusions, which you see here, and that is if it's only the exclusion. If you have schizophrenia, obviously, and an alcohol problem, then we can use the legislation. It is a very wide definition, and I think that that was done deliberately by the Milan Committee when they put this forward. It's not to catch everyone, but it's to ensure that we don't exclude people. Because when we come to the specific powers of the Act and the other criteria that we have to apply, this will then not be relevant to many mental disorders to have powers to detain individuals. The Scott Review, and I see Lord Scott with us today, has opened up really with a whole discussion on the term mental disorder. I have to say, I myself have attended so far 5 workshops on what is a mental disorder. Those are 10 hours of my life I will not get back, Lord Scott, and we are still certainly not there in that definition. So my role is to talk specifically about psychoses, and some different types of psychoses are listed at the bottom of the slide, but I want to primarily talk about schizophrenia. So this is a severe mental disorder characterized by a breakdown of thought processes, of contact with reality, and emotional responses. What is a psychosis? It is being out of touch with reality. Typically, in schizophrenia, individuals may experience the thoughts that the thoughts are being broadcast out loud, that thoughts are being inserted into their head or withdrawn from their head. And delusions and hallucinations are very common. So a delusion is a false, fixed idea that cannot be argued again, that is unshakable, that is out of keeping with cultural norms. So if I say that Lady Dorian is an alien from outer space come down to take over the world, for most of you, you will think that that's a delusion. There may be one or two not so sure. If I say that 2,000 years ago, there was a man died on the cross to save us from sin, who came back to life, regardless of whether you believe this or not, this is a recognized cultural norm, so is therefore not delusional within our culture. So delusions, you can have persecutory delusions, people after you, grandiose delusions, religious delusions, various types of delusions. And then to hallucinations. A hallucination is a percept without an object. So you see the microphone, you see the gavel, and there's an object there, and this time on the sense of vision, we all see those. If I then say to you that I see a snake on the table, I may be genuinely perceiving that I see a snake, but there is no snake there. Now, if anybody's seeing a snake, come see me afterwards, but you'll agree. So, you can have hallucinations in any of your 5 senses. Typically in schizophrenia, it's auditory hallucinations, voices, giving a running commentary of what you're doing, 2 voices often talking about you, and generally, the thing about the voices is they're usually horrible. So those are the positive symptoms. Alongside that, people may have a very flat emotional response, blunted, or they may be incongruous, giggling when you get arrested by the police. Their speech may be incredibly difficult to follow, and that's mirroring the patterns of their thoughts, and that's what we call thought disorder. Sadly, schizophrenia is associated with impaired social functioning. So after each episode of positive symptoms, the individual's ability to function as they would otherwise have functioned, to hold down the same level of jobs, relationships, independent living, is likely to deteriorate. Just under 1 in 100 risks for any of us getting schizophrenia. It's early onset, men, late teens, early 20s, women 5 years later, for reasons we don't know why. It can, of course, occur across the lifespan, but it means, as it's often in the young, this is a long-term disability. Now, the good news, if there is good news, is that treatments have moved on, and these treatments really can help the positive symptoms of these disorders, allowing people now, with a whole package of support, psychological, social, to live much of their lives in the community. For us, very sadly, one of the issues is that in fighting stigma against people with schizophrenia, there is an association between schizophrenia and violence. And whatever sort of study you look at, there's, roughly speaking, a times 2 to 4 increase in the risk of violence for men and 6 to 8 times for women. And that's because women are much less likely to be violent in the first place. Now, if I had a magic wand and could get rid of all schizophrenia from Scotland, I would reduce our violence rates by 5%. And this is what we call the attributable rate, and that would be significant. Approximately 20 to 40% of people who have schizophrenia will be aggressive at some stage, which of course means that 60 to 80% are not. 50% will themselves be the victim of a violent offence, and 10% will commit suicide. And one of the big issues around schizophrenia is insight. That's a lack of understanding that I have an illness and may need treatment. And this is not an all or nothing concept. It can fluctuate. But that very much plays into the issues of responsibility, particularly for offending and sentencing, that we will be discussing later. Personality disorder. Been asked to touch on this. Personality disorder is a deeply ingrained and maladaptive pattern of thinking, feeling, and behaving, persisting through many years, that develops from adolescence onwards. And that's the time that the personality begins to fix. And this causes suffering to the individual, to others, or to both. And roughly, very roughly, just under 1 in 20 of us in the community will have some form of personality disorder. And again, there are various subtypes of personality disorder, and for our purposes today, it's highly likely to be the dissocial and the borderline that you will see in the courts. Now, please remember that the relationship between mental disorder and offending is complex. If I kill my mother because I think she's been replaced by an alien and I need to free her by killing that alien, there's a very strong association, and you can see there. But often, these are people coming from disadvantaged backgrounds, all sorts of problems. poor parenting, social deprivation, low intelligence. We heard some of these listed earlier, and these are all relevant factors, and all factors that we address when we have people in with us under our care. Now, this is a very important slide. This is the links between the criminal justice and the mental health systems. And what I want you to know as a take-home message is that at every stage of the criminal justice system, from first contact with the police to being a sentenced prisoner, we have powers, either directly or to recommend to the courts, to assess and, where necessary, to treat. And this does not stop the justice process from going ahead, either in tandem with that assessment and treatment or at a later stage. Now, primarily today, we're interested in post-trial when we're reaching what to do with somebody. And just at the bottom there, it shows you, even if they're acquitted, we can still assess. If they're sent to prison, as we've heard, we have powers to transfer to the relevant level of security for further assessment and treatment. And whether they're convicted or acquitted, there are a range of powers that I will show you for a suitable disposal of these individuals. Here is an important reminder that the threshold for detaining mentally disordered offenders is lower than for civil detention. In other words, we don't have impaired decision-making ability in the criteria for mentally disordered offenders. The court, of course, has to consider all circumstances and alternative means of disposal. And the other criteria here, treatment, risk, very broad, health, safety, welfare of patient, or safety of patient, safety of others, and necessity all apply. We are awash in mental health and legislation to assist these individuals, and that's why I say nobody should be lingering behind a cell door unassessed, uncared for. And these are the powers pre-sentencing. These are the issues at trial, and I must say it's rather good when you have the Lord President and the President of the Mental Health Tribunal as your warm-up act who've taken us through these issues. So it's a reminder here simply that we do have all of these issues to consider at trial, but Lord Calloway addressed those. And then very importantly, and Laura did talk on some of these, about legislation. And this is when we're getting to sentencing and disposal. So what do we have available to us? Compulsion order. 2 minutes?
2 minutes.
Compulsion order, about 40 to 50 per year. Restriction order, about 10 a year. Hospital direction, where it's a prison sentence, but starting in prison. For those with incapacity, guardianship and intervention orders. And then we have community options. And then we have the TTDs. The figures that Laura gave, really important, because there has been a decline, notable decline from about 40 odd to 20 odd in the use of the transfer for prisoners. So who do we have? These are people, 65% male, late 30s, early 40s. This is the whole high, medium and low secure across the Forensic Network census, often from deprived backgrounds, 40% physically abused, 20% sexually abused. For just over 10%, this is their first admission to psychiatric services. They're all detained, a third on the most serious under restriction orders. 70% have schizophrenia, 17% learning disability, and the comorbidities there, alcohol, drugs, and personality disorder are common. What's our system across Scotland? We've got high secure, 3 medium secure units, and about 220 beds in the low secure, 50 of which are in the independent sector. All prisons, apart from the open prison, have mental health teams with visiting psychiatrists and psychologists. There are liaison services, and I use that word rather than diversion, and we'll maybe explore the difference later, to courts and police cells, and there will be community forensic mental health teams with varying remits across the country. So what are our outcomes? This is a 20-year follow-up from the state hospital, but this is before we had medium secure, so it would really now take into those patients as well. 88% left high secure, over 50% reached the community, symptoms of psychosis improved, the recidivism rate, 23% overall, generally very minor, 8% violent, but nobody seriously injured, and no sexual assaults. Very poor social and functional outcomes, nobody in paid employment, very few in an intimate relationship. And sadly, 37% died at an average age of 56, men losing about 15 years of their life, and women 24. And the cause is not suicide or unnatural deaths, it's cardiovascular disorders and respiratory disorders. And the patients talk poignantly of the stigma and isolation they feel once they are in the community. So, questions for you as a whole. Sentencing for psychosis, I've actually got the easy bit. We've got a whole system to deal with psychotic people. My colleagues have the more difficult bit. Does it work? When we hear about the other mental disorders, what have we got? Does it work? What should we do? What role do mental disorders play as a mitigating factor in sentencing? The so what question. So what if somebody's had a head injury? Do we need specialist courts for people with mental disorder? And what should we do to make our prisons more therapeutic? Because in the end of the day, for some of the people you deal with, they're obviously going to end up in that situation. And we've done a lot of work recently with Scottish Government exactly on this issue. Thank you very much.